Yeah,
Can you full screen it, Cam?
yep. Can you see? Okay. One. All right, over to you.
So we're very fortunate today to have an ear, nose and throat surgeon come up from Melbourne. So Dr. Perry Burstin has been part of the postural orthodontics program for a few years since we started our journey during the COVID times. He is a graduate from the University of Melbourne and completed his ear, nose and throat training in various facilities in Victoria, and also his head and neck fellowship in Dublin in the United Kingdom. Currently, he's practicing in Armidale in Melbourne, and big focus on pediatric and adult airway management, and also sleep disorder breathing treatment. A lot of his work is based around sinonasal disorders, as well as functional, aesthetic, and reconstructive septorhinoplasty. He also is a volunteer in various third world health clinics and operates around the Pacific Rim. So we have a local surgeon, Professor Narinder Singh, who will be part of the Q&A panelists. He's an ENT surgeon who spoke during one of the earlier webinars we had this year. He's a professor of surgery at the University of Sydney and chief otolaryngology head and neck surgery at Westmead Hospital in Sydney. So rhinologist specializing in disorders of the nose and sinus, including nasal obstruction and surgery for snoring, as well as, of course, obstructive sleep apnea. Complex and extended endoscopy, sinus procedures, anterior skull-based surgery, and rhinoplasty. Professor Singh has special interest in the role of nasal obstruction in the pathogenesis of dental and maxillofacial disorders, which is basically what we are also interested in. And he's considered to be the go-to ENT for our profession, the orthodontists, the max-fax surgeons, and the craniofacial pain specialists across New South Wales. So please welcome Mr. Perry Burstin, who will give us a talk on, let me share screen.
Yes.
Oh.
Beautiful. Thanks, Simon. And the little Duba.
Just make sure.
Who did that? One of the participants mentioned that I looked younger in that photo, and I I can't even remember when it was taken, but I realized that it was 3 sets of glasses ago. So it must have been a while back. I've been under a lot of stress, clearly. I like the photo about the snot because it's certainly my favorite secretion. And Indigenous patients have snot trains. It's one of the reasons why they get such terrible middle ear problems, because they have this this cast of snot going all back to their nasopharynx. I'm glad I've got Narinder here because he can heckle from the seats up the back. And if anyone wants to interrupt or ask me anything at any time, please go ahead. So I've titled this "What the Dental Practitioner Needs to Know About the Airway," that was too busy to ask about. And this was just to make sure that you were awake. So does anyone know where this particular picture comes from? It's a Salvador Dali, and it's just this beautiful depiction of, art, science, and craniofacial image. So there are the known knowns, known unknowns, and unknown unknowns. And this is the difficulty with when you cross specializations here, that you've got to know what you don't know. And I think that's where I like these collaborative approaches, that we can all sort of share our knowledge. So how did I journey into this collaborative area? And I can think of two instances which really changed the way I practice. Because as I was saying to Simon last night, the only time that only two times that we had dealings with dentists back when I was training was, one, if you did a maxillary resection and you needed a dentist to come in and fit an obturator so that food wouldn't come out the patient's nose. That was one. And I was thinking about just before I went to sleep, and I realized there was another instance where we had a patient with Ludwig's angina who needed a tracheostomy, huge submental and upper cervical swelling, and they also needed their tooth root, an infected tooth root removed. But that was the only time. And now, a significant proportion of my practice, and I'm glad to say so, comes from dental fields and dental referrals. And by and large, the patients are very well worked up. The patients are very, very pleased to have this collaborative input, and they understand why we're doing it. And so the two instances that really changed the way I think was when I saw this picture, and it was about towards the end of my training. And what it really sort of depicted was these Da Vinci ideals of facial proportions, because we know that what looks good functions well, and what functions well often looks good. So there's this symbiosis. So that was one thing that changed my approach, because I started looking at the face and not just the nose. And the other reason was we were doing palate surgery on patients. And I'm sure that Narinder can remember the times when he did lots of UPPs. And, perhaps it's my underlying requirement to be praised and to be thanked for what I do. But it really upset me that I wasn't sure when patients came back to see me after palate surgery whether they'd be happy or not. And I really didn't like it. Made me feel uneasy to be a crapshoot as to whether they were going to get a good result or not. I didn't know. I had no predictability about whether they were going to do well or not. And then I realized that it wasn't what I was doing that was the determinant. It was actually the chin position. It was this bit down here, which was going to determine where the tongue was. That was the big determinant. And another really formative point was when I think it was about the week before COVID hit us in Melbourne, and there was an integrative meeting run by Shireen. It's where I first met Simon, where I first met Narinder, and I thought, isn't this fantastic? We really have gone full circle, that we had dentists, orthodontists, speech therapists, sleep physicians, facial surgeons, ENT surgeons, pediatricians, all in the one room. Because we've been doing multidisciplinary head and neck meetings for cancer for ages, but never, to my knowledge, have we really formalized this collaboration. And I think that was a really huge leap forwards. So this is a practical-based lecture. It's not going to be encumbered by references. I'm really just going to focus on what I think you ought to be thinking about, and that is some degree of airway assessment. It'll be mainly focused around kids. I don't think we'll have time to look into adults and sleep disorder breathing. But I always just wanted to point out that this is a multi-level and multidisciplinary approach. So we know that nasal obstruction is very common. And the thing that I think you really want to ask yourself is, how bad is the kid And are they a mouth breather? So you know all this, okay? I'm not really here to talk about, you know, is there snoring, heavy breathing, apneas, pauses, arousals, agitated sleep, sleep disturbance, sleepiness, fatigue, bruxism, behavioral issues, cognitive problems, inattention, concentration, hyperactivity, reduced focus, enuresis. You can look all of that up on a checklist. All right, you know all those symptoms. All right. Really, what I want you to focus on is, are these things there? And should I be dealing with them? And if so, how am I going to go about trying to fix that? So the first thing is you just got to look at the patient's upper airway. I remember about 10 years ago speaking to an orthodontist, and I asked him about whether he refers on to airway surgeons, and he goes, I don't look at the airway. I'm a teeth specialist. And that must have been the prevailing view, how he was taught 35 years ago. But I don't think that's the way we should be learning right now. So it's not hard. You just need a light source, nasal speculum if you've got one, the tongue depressor, and the old adage that more is missed by not looking than not knowing. And this is me doing an EUA in the Pacific. You can see my anaesthetist is doing things old school. He's got a mask over the patient. He's got them spontaneously breathing. I'm using a borescope, which is our light source, and I'm just basically looking at the kid's ears. Normally I'll do it under a microscope, but I just want to show you that it's really easy and you've got lights. There's a speculum. We use metal ones, but there you can see there's a major septal dislocation to the right. And I think you can see that they're pretty decent sized tonsils there. So in kids' airways, what do you need to know? You just need to look at the front of the nose. We need to think about the adenoids and we think about the tonsils.